after someone is discharged, what is the most vulnerable point?
Oh my God, this is a reality. I am going to be inside and I don't know if I can take care of myself.
Ready for discharge doesn't mean that the home is ready for you.
Welcome to the Empowered Elder Podcast.
So thank you so much for joining us. We really appreciate you taking your time. And, you know, it was great meeting you when we were in Atlanta, and we're very excited about this conversation.
Well, thank you so much for having me. I'm really excited to be a part of your podcast.
So let's start a little bit with your background. How did you get to where you are today?
Okay, so first off, I come from a family of healthcare providers, spanning nursing, social work, case management, physicians, and we all like to serve. Right from the beginning of time, I knew I wanted to serve. So I knew I wanted to do something in the healthcare field, and I knew I wanted to help people. So that's really how I found myself in healthcare. And furthermore, I knew that I like the positive aspect of healthcare. With physical therapy, it doesn't get worse from where, they meet you. It only gets better. So I wanted to help them get better. And if it doesn't get better, then we refer them back to their physician. So that's really, just in a nutshell, how I found myself, getting involved in healthcare, which is the first part of my career journey. And obviously, as you know, more recently, I've gotten involved into home modifications and aging in place. It's becoming almost like a profession, aging in place. And when I say school, I mean like bachelor's and things like that, which I'm not too sure about, but that's something that I want to further look into. So it's important. It's of importance.
Hopefully that will translate into more geriatricians as we move forward. That's definitely a
low number,
a big gap that we have nationwide, let alone in our local communities.
Absolutely.
So was there a single moment or story that you can kind of come to that you thought, okay, we can't separate the idea of mobility and the physical environment?
It did, because I worked in the hospital for over 14 years. I started my clinical journey on the critical care unit and the cardiac intensive care unit. And it was a rotating hospital, Montefiore, located in the Bronx. A lot of exposure in that hospital. And like I said previously, PT is a part of the discharge dispo. So I saw that they would come to us and ask us to assess the patient's mobility while they're in the hospital. And they would ask, is this patient safe to go home? And we would have to document. And we would also have to present our recommendations to the client and the caregivers. And a lot of times they would cry on their bed. They'll say, I want to go home. I want to go home. And God forbid it's a holiday or one of their loved ones getting married. It makes it even harder, right? And I have the onus to recommend to my patients what I feel would be best. Now, they don't have to take my recommendation, but as a professional, we offer best practice advice. And I would say, you know what? I don't think home is safe. I'm recommending subacute rehab or skilled nursing facility or whatever have it. And that really broke my heart, because sometimes they have caregivers in place that can take care of their needs at home, but the home environment cannot take care of their needs at home. So I said, okay, and this happens quite often. Then fast forward, I found myself working in home care. I've been in home care for about 8 years now, to be exact. And I saw things from the other end. Now I'm in the home environment. And sometimes I'm like, how are you discharged home? This is totally unsafe. Now, once again, patients can refute discharge recommendations. So perhaps they just adamantly say, I'm going home. I don't really care what you have to say. I want to go home. But how are you here? This is unsafe. So, and then, doing home care, we all know that home care is only for 3 to 4 weeks. Perhaps they extend, the length of stay, the home care services. Perhaps they'll give you an additional 2 weeks, but it's really short-lived. And when you get in there, you may say, perhaps you might want to pull up the rug, like I said, or perhaps you might want to consider a grab bar. But they're not there to assess your home environment comprehensively. And even more so, they're not there to put you in touch with a contractor or an elder law attorney to see how you can channel your funds and your assets. They're not there to get a geriatric care manager in place. We're really there to restore strength, function, and activities of daily living. So that was those two experiences is really what made me say, something has to be done. And why is something not being done? It was almost like a no-brainer, right? Like, why is this not happening? And I had to sit with myself and evaluate. And that's how I ended up saying, you know what, I want to bridge the gap. So a lot of times I would say, bridge the gap. Let's bridge the gap between healthcare and the housing environment. So those are the experiences that really shaped me, that got me to where I am today with Opt to Restore.
It's kind of like the patient gets the discharge, right? And you say, and there's that sense of excitement, but yet there's that sense of fear because I'm going home, but what does that really look like? Do you think that they're most vulnerable? Like, does that set in like when they're actually in the car? Is it when they get to the front door and they start to like, oh my God, this is a reality. I am going to be inside and I don't know if I can take care of myself. Right. So when do you see that typically setting in?
It's when they get home and they realize that the steps that they used to navigate is foreign to them, right? Or the bathroom that they used to just lift their leg up, above the tub is now strenuous, and they're afraid. They're literally afraid. I've had times where I said to them, I am the physical therapist. You're not allowed to fall with me.
Mm-hmm.
Outside of when I'm not here, I can't control that. But when I am here, I tell my patients all the time, I said, you are not permitted to fall with me. You will not fall with me, giving them that reassurance. Majority of the times they trust me, but would they do without me there? Absolutely not. And the loved ones are terrified to do with mom and dad. They're calling saying, where's my home attendant? Or where's just the CNA, And the unfortunate part about it is that a lot of times they're only able to get in there 1-2 times a week. You're lucky if you get them to come in 3 times a week to shower you, right? So they're realizing like, wow, we have our hands full. So it's not until they get inside that they're like, whoa, this house is not meeting my needs. I've had situations where, the patient demanded to go home. Family's like, I want mom home. And they get mom home and they realize that this is bigger than, an overestimation of capabilities. They realize that this is way more than what we anticipated. And now they're looking to do a PRI. PRI is, how do we get mom back to the hospital to get her back to where she should have been because home is not safe.
And PRI, so what is that? That's just the evaluation to see if they have to go back, or what does that stand for?
That's right.
PRI?
The nurses are the ones that really get involved in that. It's pretty much a screening or assessment tool. They have to be trained in that. And they basically send it back to the hospital or the rehab in efforts for them to get readmitted, to the right appropriate place rather than home.
And nobody wants them to go back to the hospital,
Yeah.
right? That's like, if we can keep them home and keep them safe. Like, so, yeah.
They're penalized if they come back in less than 30 days. As of 2026, the penalty is even higher. So nobody wants to hear that they go back, right? The patient doesn't want to go back. The loved one doesn't want them back. And the hospital does not want to be penalized for that, right? They're like, why is this patient back? And then you get the revolving doors or the frequent flyers, right? But why is this patient back? What can we do to ensure that the patient can truly stay home and not come back? Or what can we do to make sure that the home environment wasn't what played the role in the patient coming back? It's one thing if the patient had a heart attack and ended up back. That's different, right? That's a change in medical status. But we want to mitigate situations that could have been within our control, right? Well, that's what Opt to Restore wants to do. We want to make sure that the home environment meets their functional needs and their long-term needs, right? Because sometimes you can do things now, but you may not be able to do it later. So we want to look at things comprehensively and say, we want to grow with our home and we want the home to grow with us. So that's, a lot of it requires proactive planning. So we're talking about, situations where they're in a state of crises. We probably would benefit if we talk about it when there's no crises occurring, right? And we're just being proactive because we know that we're all aging and we don't want to be displaced. So we really have to, change the way we think about home and function and aging. It really, it's a concern.
What is an example of a discharge plan that might look great on paper, but in actual application of it in the home environment, it doesn't go quite where the clinician had intended it to be once they cross the threshold of the front door?
Oh, that could present in so many different ways. So many examples that I can give for that. So like, let's say, they tell us, oh, I have a shower in the house. I have steps and I have a grab bar and I live with my daughter. Right? Sounds good, right? You have steps, but you have a grab bar. You do have a shower. You live with your daughter. You have a caregiver in the house, right? That sounds wonderful. It sounds like, and then you have at least 3+ out of 5 strengths. So you could sit to stand, right? So we recommended the walker. So you have the walker, you steady. You don't need anyone to touch you while walking. So you sound like you're set. But when they get home, what they fail to mention is that the daughter is only home for a handful amount of hours out of the day, right? What they fail to mention is that their steps are spiraled and there's only one banister, not 2. What they fail to mention is that there's minimal lighting. There's not adequate lighting in the walkway. They also didn't mention that their bed is a king-size bed encroaching on the walking space in their bedroom. What they didn't mention was that, the daughter doesn't have time to manage and organize the medications, or the medications are on the counter by the stove. I mean, or they didn't tell you the kind of flooring that they have, that it's marble flooring all over the place, so they'll probably slip and slide everywhere. Just so many things that can present itself that in the home environment that is not noticed until you're in it.
So all of this supports you really should be part of the clinician's plan of discharge with an assessment of the home environment before they take the paper and say, well, this is what the doctor told me to do.
Sure.
100%. And if you can't get it in place prior, it's never too, I don't want to say it's never too late, but it's better late than never, right? So I tell people that they can contact Opt to Restore even when Part A services are in. So what does that mean? If you get a nurse or PTOT that's coming in from home care and they say, you know what, this looks like it needs further assessment and it looks like some form of modification needs to take place, whether structurally or non-structurally, that would be a good point to flag a company like Opt to Restore or a home modification company that's well aware and informed about clinical status or healthcare comorbidities and stuff like that. And that's also well informed about home modifications and aging in place. That would be a good point in time. So it's never too late. We can be consulted when the patient's in the hospital or in the rehab center. We can get in there prior to their discharge and collaborate with the caregivers. We can get in there during Part A services or even after. At any point in time, I would say the sooner the better. It's never too late.
What do patients, families, and their caregivers miss when they hear ready for discharge?
Oh, okay. Ready for discharge doesn't mean that the home is ready for you. Ready for discharge doesn't mean that you are safe enough to be in that home environment. So you may be ready for discharge in a sense that you're not critically ill, right? And the hospital feels safe to discharge you on to the next place of stay. But that does not mean that home is it and home is safe and that you actually truly can function at home. So I think that's a myth that patients and caregivers really misconstrue, because there's a whole nother world after discharge, right? There's a whole different phase. Even for physical therapy, I tell them, okay, home care comes in. That's just the start, especially when you think of the joint replacements. That's just the bare minimum, right? We're just making sure that you can function in your house. There's a whole nother world after that, right? Which would be outpatient therapy, where you're getting aggressive rehabilitation. Really, really, they're stretching you, they're doing soft tissue mobilization, everything. So there's a world after discharge. So I feel like there is a myth when it comes to that discharge ready means safe at home and that, things are smooth sailing going forward.
Or back to normal.
Right.
Or
Ready
back
for
to normal.
discharge.
Absolutely. You're not back to normal.
Right.
Not quite, and you have a journey ahead of you. And you know what? There's a lot of support in place. There's nothing to be fearful about. I think it is something to celebrate, right? Ready for discharge. Who does not want to hear that? That's music to your ears, right?
And they're doing those before, when we talk about when you're discharged, but even before you are discharged. So there's those practice sessions right in the hospital. So the clinicians in the hospital, they're making sure that the loved one or the individual is practicing, they're getting out of bed, making sure like they can handle all of the steps. Do you find that is strongly being done, or can be a little bit more practice or rehearsed before they are released? Or what are
I
your
think
thoughts?
that is because I was that clinician that was doing that, and they prioritize in the hospital. We do have priorities, such as joint replacements or cardiac surgery or any kind of neurological or vascular patients, at least in the hospital that I practiced in. We made those patients a priority because those are like the most, and then obviously CICU, critical care patients, those patients took precedence over maybe somebody that's just having like GI symptoms or something, So we get in there as fast as we can. And there's a timeline for us to get in. We get into the rooms and we're getting them out of bed. When I think about the CICU, the open heart surgeries, we're like, let's go. And they're looking at us like, let's go. What do you mean? I have
surgery.
I have not even that I just had surgery. I have 10 lines coming out of my body. Where are we going? Right?
Right.
How?
Exactly. Right. How does this work?
That's right. I mean, it's really amazing. I was always amazed. And that's one of my favorite units, the critical care unit. I mean, we would get them out of bed, probably not even up to 24 hours after surgery. And we're like, let's do this. We're going to do this. We're going to hold your hand and we are going to get through this. And we are walking them with the lines, with the pacemaker, with the Foley cath, with the chest tube drainage, right? So hospitals are doing what they can do because we also want to minimize pneumonia and further complications. So early mobilization, which is what you're speaking about, is very, very important. And they don't take that lightly, especially the surgeons and stuff that I've worked with. They want their patients up and out of bed as soon as possible. And even furthermore, those patients, they're likely to be seen 1 to 2 times a day. There's a minimal amount of time that they have to be seen. So I think they're doing the best that they can when it comes to things like that.
Perfect.
After someone is discharged, what is the most vulnerable point? Is it the car ride home? Is it first steps into the house? Is it the first night? Is it the first couple of days? Is it when they're alone the first time? Like, where does the biggest amount of vulnerability come into play?
I would say within the first 2 days. The first 2 days, because they're at home. The nurse is not there popping their head. The physical therapist is not there at their services. So the first 2 days, I'd say within 72 hours, right? And then also if they're alone, if you're alone, it's just very different, especially when your body is not functioning the way that it was once functioning, right? I was able to hop out of bed before this happened. Now I can't. Can I get out of the bed safely? Can I make it from my room to the bathroom safely without collapsing? And that's just the functional aspect. There's the medical aspect. And then the fear, the psychological component, am I going to have another massive heart attack? If I walk up those steps, would I make it back down? If I walk up those steps, am I going to, it's a true fear. Now, I've never been in that situation, but I try to put myself in in their shoes. And that's where a lot of patient education and client education has to come into play. And then, if you introduce cultural aspects, that's another thing, right? So some cultures think, oh, mom just had surgery. She has to lie down there and not move and recuperate. Whereas Western medicine says, no, we're not doing that. If you do that, you're going to find yourself in a bigger mess. We need to get you up as safely as possible. And we need to get you moving. So I think when they're home alone during the first few days, that's where it's, very, very fearful for them and very risky, risk occur and presents itself around that time frame. Because once, after a few days or the first 1 to 2 days, if mom did it, then you're like, okay, she's fine. We're good, But those first few days are hard. It's hard.
So how does someone plan for that? How do you empower them with the knowledge and the skills and the resources to be able to kind of weather that storm?
First of all, they start the training in the hospital. Like we said, we start training them. We start showing them how to get out of bed. We start showing them how to get up and down the steps. We show them how to sit to stand safely. We show them ADLs. OTs would take them in the bathroom in the hospital. We start showing them how to put on their socks, how to come, every phase of the rehabilitation process matters. Then when they get home care gets in, and that's where home care really shines. They get in and they want to see how you're functioning. They're like, okay, now you're at home. So let's see how you're actually doing it in your home environment. And then after that, provided they need more, then there's the outpatient once again. So I feel like all of these things help collaboratively.
Do you find that when you're making modifications to the home, how do you make those modifications and allow the patient to feel more empowered and not restricted? Because whether they previously, before they had gone into the hospital, they may have been going upstairs to their bedroom, but now things are shifting and maybe the stairs out of the gate is not the best move for them. So how do you make those modifications and talk to the patient, say, we're not trying to confine you or restrict you. We're just trying to make it safer for you.
So we recommend the least amount of modifications that they need to feel safe and independent. We're not going there to uproot their life and tear apart their house. That's not the goal at all. Maybe if you consult a contractor, they're going to upsell them and say, oh, you should do this, do that. We're not there for that. And that's the nice thing about home modification professionals. And we at Opta Restore, we focus on universal design. So a lot of my training, they taught us about universal design, and universal design can be very aesthetically pleasing, right? It can be an upgrade to the house. So I put that out there right away, and I tell them, we're here to ensure your independence and safety. And sometimes we make it less about them, right? Like I'll tell my clients, we want your house to be visitable. Like forget about you. You have your friends, you have your loved ones, you have your children. We want this place to be a safe and beautiful space for your entire family to be able to function and enjoy their time with you. So it's really about your approach and how you present these things to them. And then another thing is that we have to take into consideration what they want and what they need. So when I go in and I do my assessments, I have a whole section. I mean, we give a comprehensive write-up, and I have a whole section. What does the client want? What does the client need? What are the non-negotiables? What does the caregiver want? What does the caregiver need? And we have family meetings, and we really look at things holistically. I had a patient where she was hospitalized, and I was called in by a geriatric care manager to do a home modification assessment because she fell 3 times. And the son said, you know what? we're not there and we're not dealing with this. And her kids were very, affluent and very capable of taking care of mom and dad in terms of allocating resources to give them what they need. But mom was resistant. Mom had no insight to the fact that she has a progressive neurological disease. Mom has no insight to the fact that she needs to continue to use that walker. And, the hardest part about it all is that her husband, who was 90, is still golfing and skiing. Can you imagine? He's still golfing, he's still skiing. As I was there in the house assessing the house, he was charging up and down the steps. I mean, with full speed, not even touching the banister. I've never seen anything like that. And though
Amazing.
I was not there for physical therapy, I was there for Opt to Restore doing a home modification assessment. My heart sunk every time he ran up and down the step. Because it said, I don't want this guy to fall while I'm here. But
Right.
the point of the matter is that he was agile and he had a life and he had a social life, right? And he built his life around his community and this home. So where do we find the medium between her needs and his needs, right? Because putting them in an assisted living might not be the best in a situation like that. So I had to collaborate with the geriatric care manager to say, what is the best recommendation? Are we going to modify this house for them to age in place? Do we want to consider an independent living? Or do we want to consider an assisted living where they would be able to care and provide for her needs and he'd be able to stay there? And so, there's a lot of planning and coordination that takes place here. It's not just getting in to do the modification. Ultimately they opted in for home modifications. He wasn't ready to leave his house. He wasn't ready to be in an assisted living. He didn't want people telling them what to do and how to do it. They were ready to hire the help that they needed in the home, and they were ready to make whatever minimal modifications it was that they needed to stay in place. So they installed a stair lift, they fixed the carpeting, they downsized on the bed, just things like that, really helped them to get what it was that they wanted and what it was that they needed, where they didn't feel stripped of their decisions and their goals and stuff like that.
And I would think even coming into consideration would be the cost factor, right? And adding that into the decision making, like what would it cost to do the modifications versus, if they were to move into a community, what does that, I mean, looking at the whole picture, right? It's like you said, it's planning. It's not just, let's just make a decision. It's like, let's take all of the information and decide what's going to be best for the individual or individuals, right?
Well, we paint the picture, right? Like home modifications can be as small as $60, maybe $500 if it's non-structural, right? But what does it call if you fractured? What is the cost of a fracture? What's the true cost of a fall? Or what's the true cost of a hospital stay, right? Hospital stays can cost them anywhere from $10,000 to $50,000, right? And then if they are institutionalized, like if they're sent to an assisted living, that can go anywhere from $6,000 to $16,000 a month. So we try to put these things into perspective and we try to put everything on the table. These are your options. I cannot decide for you, but I can lay out the pages and show you comprehensively what this would look like now and in the long run. And then it allows them to make a more informed decision, and it allows their loved ones to make a more informed decision. And they do. It comes with tears. I've had them, it was me, a nurse, and, they started crying. And she said, this is beautiful because that means that you are human and you care. We said, well, what do you want most? I asked, what would be the best case scenario for you? What do you want as a caregiver? And he said, you know what? I want what's best for my wife. Even though the assisted living was not on his radar, but he said, I want what's best for my wife. And I think that's what matters most. We all want what's best for our loved ones. And as providers and professionals, we want what's best for our clients and patients. So we're all on the same page. We're all on the same page. But if you start, if they need to make modifications and they don't consult people like you and I, they could find themselves in a bind, and they could find themselves wasting thousands and thousands of dollars and time. And it just goes on.
Some of the historical beliefs around the aging in place and home modifications is that you're going to make my home feel clinical and hospital setting. How do you bring design elements in to maintain that home feeling while still giving the clinical needs, the appropriate attention?
So I like to take pictures and stuff to show them what home modifications can truly look like. And there's been some home modifications where it's a total upgrade, where brass finishing, the grab bar matches the sink and the vanity. It matches the fixtures, the light fixtures. There's a ton of things out there that can make things accessible and visually appealing. And if it's even above me, I have an eye for universal design and aesthetics. I sometimes even bring in an interior designer. So it depends on what the needs are of the client. And that's why I like the CAPs, because you do have interior designers that become CAP certified to work with professionals like me. So this brings us back to our previous discussion, of collaborating and giving the client what they need. So there's ways to beautify their home whereby it's not a downgrade. You don't feel like you're in an institution. They have microwaves where, you eject it and it's at a accessible height. It's beautiful. You just plop the glass plate in, and it's gorgeous. And you don't have to strain your back, right? You're not trying to strain your hand if you have carpal tunnel or spinal impairments. So it's come a long way. Universal design and decor, when it comes to accessibility, has come a very long way. And a lot of people are well informed and willing to work together in that space.
That's great. If we can transition a little bit, I want to touch on how the opt to restore the care model. And I'd like to dive into that a little bit. And if you can explain to our listeners what the care model is, and what problem were you seeing that made you realize it's important to have a standardized framework? And let's put this in place. So if you can tell us a little bit about that.
Because like I said, we're operating in silos. And, as a clinician myself, I still practice physical therapy and I love what I do. I'm not collaborating with contractors from the clinical space. I wasn't collaborating with contractors or interior designers or elder law attorneys or financial advisors. So the CURE model opens up a space for us to collaborate collectively and formally. So the C would be for clinical assessment. We get in, we assess their past medical history, their history of current illness. And then we would go in and assess the high. So first of all, they can send a referral via the CURE signal. We have a CURE signal where any provider can fill it out. It's on our website. It's HIPAA compliant. So it's just simply saying, hey, I have Joan Smith that I'm referring to you for a home modification assessment. This is minor, moderate, urgent. Perhaps Joan Smith has a progressive disease and the home environment is unsafe. We will take that in. We would call Joan Smith. We would assess, like I said, her past medical history and current history. And then we would get into the house and we'll assess the high risk areas. And then from there, we would collaborate with, we'll make recommendations and collaborate with trusted professionals that are licensed and insured. So whoever it is that we need that needs to come and do the project and make sure that things are well executed and well sustained, we will bring them in on the project. And then, at the end, we'll evaluate to make sure that things were done accordingly, and we'll do a closeout, and then we'll communicate back to the referring professional or provider that things have been well done, it's implemented, Joan Smith is safe, they're happy, and then we'll also provide them with a report. So it's just a way to standardize referral and coordination between the clinical care and other cross-sector professionals outside of clinicians and healthcare. And I'm hoping that institutionally, we can formalize this and find a way to standardize a process, once again, to enhance aging in place and safety, when it comes to decreasing risk and falls, mitigating falls.
Where does communication normally break down between the different segment of service providers?
I would say lack of formalized assessments or lack of formalized referrals. I mean, why does an elder law attorney have to communicate with a physical therapist, right? They're just not communicating. There's no need. We're not in each other's view, right? Like we look at our professions as separate entities. We're operating in a silo. So that's really where the care breaks down or communication breaks down. PTs don't feel the need to communicate with a geriatric care manager, or they don't feel the need to or perhaps elder law attorneys don't feel the need to communicate with financial advisors. We're all good at what we're doing, but there's no need for us to have to collaborate in that regard, unless you're like you and I, where we have an eye and we have a love or yearning for aging in place. We'll kind of step out the box and say, hey, my name is Comfort Uwadiaei, and I am a physical therapist by profession. And I noticed that my client could benefit from modifications, but they have concerns about finances. What can you do to help Joan Smith, ensure that she can afford such, right? Or locating aging, organizations to say, hey, I have Joan Smith. She's 75 years old, and I feel like she'll qualify for a waiver. She doesn't make more than $70,000 a year. And she had, so it's taking that extra step, but we're not mandated to do that. I guess that's what I'm trying to say. We're not mandated to communicate between cross-sector professionals. And we kind of get engulfed in what we're good at and what we do. And once again, this is the reason why I created Opt to Restore as a way to bridge and formalize that communication and referral process.
It's kind of like you were relying on the patient to have to relay the information from each individual professional that they're working with, and information can get missed or not, shared. Like, so if I need the resources, then it's, as the patient, it's up to me to go to my financial advisor, or it's up to me to take this information to my estate attorney. But if nobody's having those conversations where it's really the core is the patient, but then the patient is responsible for relaying their own information. And if information gets missed, then the patient is not doing. It's like a vicious cycle, right?
And that's the system that we have in place right now. That is the system. You are responsible for figuring it out. We've discharged you. You're done with acute care. We've discharged you from home care.
Right. Yeah.
That's on you and your family to figure out.
Sure.
And imagine having to navigate that when you are newly diagnosed, or you just don't even have the strength or the cognitive capability. Imagine having to navigate all of those parts, where as a caregiver, a lot of caregivers are still raising their own children and they still have their own family. It's challenging. And that's where Opt to Restore can really alleviate the burden. And that's why I say we specialize in care transition. We understand the hospital to home aspect. That's what we're highlighting: hospital to home, rehab to home, staying at home. We can alleviate that burden by taking up the task and putting the onus on us to coordinate your care. And that's not just clinical care, it's your comprehensive care. We can be of assistance in that regard when it comes to care transitions and aging in place.
Really, it also sounds like you can take the pressure off of the family to be the police of the process, right?
I say that we're like the project manager, so to say. I didn't realize that that's what it was, but it's almost like project management between professions and discipline, making sure that things are well executed and done well and well sustained, right?
That's true. We know a lot about project management. So
Yeah. Yeah.
When people don't fully comprehend, I think that's the best way that I can explain it, where they say, oh, yes, coordination, making sure that things are done in a timely fashion, right? And making sure that we're delivering on your goals, needs, and aspirations.
What's a good conversation starter for a family, caregiver, friend to have when they know that changes are needed, but they don't want to offend the elder?
That's almost always the case, right? Like the elder does not want to hear from their junior. The elder does not want to hear from their child. They don't want to be told because they've lived a life. They raised you. I tell you, you don't tell me what's good for me. And a lot of people in their 90s, they have their wits. They have their wits. They're really cognitively intact. So it's like, you're not going to tell me what's best for me. And more than that, you're not going to make decisions on my behalf and totally disregard my input. But that's where bringing professionals in on the subject matter to say, you know what, mom, she's a professional in this space. And I think we could benefit from her input and her guidance. And that has been the going thing, at least with Opt to Restore. They'll say, we need their insight, we need their input, or even husband and wife, right? Forget about mom to children. Husband and wife, you don't want your spouse being upset with you. You don't want to feel like, they've abandoned you when you're in a place of need or in a time of need, right? Or disregarded you totally. They take it to be insulting. So bringing people like us in and say, you know what, I totally get what it is that you're speaking about, and it's totally valid. How about we look at it in 3 different areas and see what best meets? How about we find a middle ground? This is what your spouse is trying to say, but maybe it's not being communicated well. What they're trying to say is that they love you so much that your safety and your independence is your top priority. What they're trying to say is, you know what, he has to be away from the home for 10 days, and he want to make sure that you can maximize your independence. And that's the reason why I'm here, to figure out how can we do this, to make sure that nobody has to tell you what to do, and to make sure that nobody has to encroach on your space. I know you don't like the home attendant in your house, and I totally get it, because I wouldn't want one there either. You want to be relatable, and you want to understand and reiterate what it is that they're feeling, right? You want to bring yourself and put yourself in their shoes. And once again, it's easier coming from a professional, right, than to come from a loved one, right? It's just much easier. It's easier to say the doctor said this. The doctor said, if you don't consider this, this is the outcome. And we both don't want that outcome. So what are we going to, and then you bring it back to them. What are we going to do about this situation? How do you think we can tackle this situation, mom? Or how do you think we can tackle this situation, honey?
What do you think aging in place is going to look like in 10 years?
Oh, I think it's going to be amazing. I think people are going to be living their best life. Back then, 60 was old. You're done. You're 60, you're done, And it's so beautiful because I'm not there yet, but just to see the shift in people that are even older than me, the mindset shift, it's like it's new beginnings. It's a fresh start, and they're looking forward to it. It's not something dreadful at all. They understand that, they're strong. They understand that they're active. They understand that they have a community. They understand that they have choices. Oh my goodness, aging in place is going to be something beautiful and out of this world, and it's happening now. I told you about the 90-year-old. He's golfing and skiing. Do you think a 90-year-old would have had the audacity to do that years back, even if they felt like they could? No way.
When we were teenagers or in our
No.
20s, we thought 40 was old.
Right.
But now it's encouraged to live your best life and be as independent as you can. A lot of them don't want to even live in a senior environment. Anything that remotely reminds them of being a senior, they want nothing to do with it. I interviewed one of my clients, and, his wife said, he likes to be amongst the younger generation from the beginning of time. He wants to surround himself with younger people. You know, he's 91. He doesn't want to be around people in their 90s. He wants to gain and just live a youthful life. So I think once again, awareness is really taking place both from the client's end, the patient's end, provider's end. We're all becoming well informed. I mean, look at your podcast, the Elder Podcasts. You know, this is because you're well informed about what's taking place in the space. And it's beautiful. I can't wait to see, because I'm living life vicariously through them. It's almost like a lens for me, right? You know, so it's
What it
beautiful.
could look like.
Right.
What it could look like.
And what it
And
could
then
look
we
like.
put our-
Absolutely.
Our
I asked my
mindset to
patients,
it. Anything is
I asked them,
possible.
you know, what did you do? What's the secret? You know, I understand that no two people are made the same, but I want to know, what are you doing? What did you do to live this youthful life? I mean, yes, you have comorbidities. Yes, you have diabetes, you have hypertension, but you're still functioning and you're still living a holistic life. I want to know.
We had a family member that we asked that of, she was over 100, 104, 105. And we said, you know, what's the secret to your longevity? And she said, a shot of Jack every morning.
I've gotten that too. A glass of
Right?
wine every day, or a piece
you
of
know,
chocolate.
Well, there's exercise and there's a shot of Jack every morning. So
No,
whichever works for you, right? It's all good.
Whatever
But I
works
think
for you.
the important part is the conversations are being had, right? So,
That's right.
and people are collaborating and getting the word out, so that in, you know, as Tasha had asked you, what's it going to look like in aging in place in 10 years? Well, it's definitely going to look different because of the conversations that we're having. And truly, this is one that adds to that and giving our listeners just a more insight into what that space could look like from a discharge, and then, you know, what aging in place is. We do have a lightning round that we do with our guests. We just ask a question or a few, and the first thing that comes to mind, it can be one word, it could be a sentence. There's no rhyme or reason. It's just the first thing that pops to mind. Is that okay?
I love that. Okay, let's give it a shot.
All right, here we go.
A home feature that quietly predicts trouble.
Dim lighting.
The most overlooked risk during the first night home.
Steps.
A safety upgrade that does not make a home feel clinical.
Nosing strips. Stair nosing strips.
One product families buy before they really understand the problem.
Marble floors.
Ooh, good one. One question every family should ask before discharge.
Is the home truly safe?
A phrase that you wish families would stop using with older adults.
Mom and dad, you're getting old. We're all getting old.
Right, we all are, absolutely.
A design choice every new home should include.
Widened doorways.
Most underrated member of the care transition team.
Elder law attorneys, because with these things come a lot of financial implications and legal implications.
One room that reveals the most about someone's independence.
Lower extremity weakness.
One myth about aging in place that needs to go.
It's only the elderly getting old. That's a myth.
That's a good one.
That is a good one.
All right. And the last is, after all of the homes that you have walked through and all of the patients that you've helped, what has this work taught you about what people are really trying to hold on to when they say, I just want to go home?
Dignity and independence.
Thank you so much
That's
for your
great.
insights. This has been an amazing conversation.
Thank you so much.
Thank you. Such a pleasure. This was wonderful.
Is there
Really
anything we didn't ask you that you wanted to cover today?
Absolutely. So if you have a loved one, or you know anybody that has a loved one that might have concerns when it comes to aging in place, it doesn't have to be that they're in a crisis. Perhaps they want to be proactive. We'd love to be of service and see how we can collaborate and help out. We have HIPAA compliant forms on our website for both professionals, caregivers, and clients and patients to be utilized. And our website is www.opt2restore. That's OPT number 2. restore.com. And we would love to be of service to you and the community.
That's
Great.
fantastic. And we'll also have your website in our show notes, so for easier access.
Wonderful.
Thank you once again for joining us. We really appreciate your time, your insights, and your professionalism.
Thank you so much.
My pleasure.
Today's conversation reminds us that coming home from the hospital is not always the finish line. For many older adults and families, it is the beginning of a new stage of recovery, one that happens in bedrooms, bathrooms, hallways, kitchens, and all the familiar spaces of home.
When the environment supports the person, recovery can feel safer, calmer, and more manageable. But when the home is not prepared, even everyday routines can become stressful or risky.
We talked about the discharge gap, the moments families often do not know to prepare for, and why small details like getting through the front door, using the bathroom, or moving safely at night can make such a big difference. Dr. Uwadiaei gave us such an important way to think about recovery and aging at home. The home is not separate from the care plan. It is part of the care plan. The layout, lighting, bathroom setup, stairs, furniture, routine, and support system all shape what daily life feels like for an older adult trying to recover or remain independent.
And one of the biggest takeaways from this conversation is that families don't have to wait for a fall, a hospitalization, or a crisis. Sometimes the most meaningful changes begin with observation, conversation, and asking better questions. What feels harder than it used to? Where does my loved one feel nervous? What part of the home no longer works the way it needs to? Comfort, thank you so much for sharing your expertise, your compassion, and the work you're doing through Opt2Restore to help older adults and families navigate recovery, care transitions, and aging in place with more confidence.
And to our listeners, if today's conversation made you think about your own home, a parent's home, or a loved one's upcoming transition from the hospital, we encourage you to start small. Look at one room. Notice one routine. Ask one question. Planning ahead does not have to be overwhelming, but it can make a meaningful difference.
You can find more information about Dr. Comfort Uwadiaei and Opt2Restore in the show notes.
I'm Tasha Beckman.
And I'm Nicole Robilotto.
And this is the Empowered Elder Podcast,
where we talk about home, heart, and the next chapter of life.